Welcome to Health Matters, brought to you by the Office of Correctional Medicine at Southern Illinois University School of Medicine. In this video, we'll explore the Wong-Baker Faces Pain Rating Scale. We'll go over patient instructions, accurate pain assessment, and proper clinical documentation. This video is intended for educational purposes only and is designed for healthcare professionals. It does not replace clinical judgment, institutional protocols, or professional medical advice. Always follow your facility's guidelines and consult appropriate experts when making patient care decisions. The creators assume no responsibility for how this information is used in practice. The Wong-Baker Faces Pain Rating Scale has 6 faces representing increasing levels of discomfort. The scale starts with no pain at all on the far left and increases to the worst pain imaginable on the far right. Each face has a coordinating number that you can use to describe the pain intensity. When it comes to collecting a pain rating, it is important to introduce the Wong-Baker Faces Pain Rating Scale and explain it to the patient in clear, age-appropriate language. Identify the anchors of 0 as no pain and 10 as the worst pain imaginable. Instruct the patient to select the face that best represents their current pain level. Then confirm the selected face and note the corresponding numerical score. Lastly, document the pain score 0 through 10 in the medical record, ensuring the scale used is specified to support accurate assessment, continuity of care, and clinical decision-making. If possible, introduce the scale when the patient isn't in pain so they understand how to use it. The tool works well for anyone 3 years and older who can point or indicate a choice. Use the faces and numbers together to help people who find numeric scales hard to use. Pain assessments must include the use of a validated pain measurement tool. One example is the numeric rating scale, 0 through 10, which should be used by patients who are able to self-report using numerical values. Another option is the Wong-Baker Faces Pain Rating Scale, which should be used by patients with communication barriers. Lastly, you can use observational tools such as the FLAC scale, which should be used for patients who are unable to self-report pain. Always be sure to document the specific scale selected and the patient's reported pain score in the medical record. When documenting the reported pain level, the OPQRST framework is a standardized method to assess and document pain in a clear and consistent way. OPQRST is an acronym for onset, provocation or palliation, quality, region or radiation, severity, and time. Onset refers to the timing of when the pain began and whether its development was sudden or gradual. An example of what would be recorded is, pain began 2 hours ago, sudden onset. Provocation or palliation assesses the factors that exacerbate or alleviate the pain. This would be recorded as, pain worsens with movement, partially relieved by rest. Quality addresses the patient's description of how the pain feels. When feasible, document the patient's own words to accurately capture the character of the pain. Record this using common descriptors such as sharp, dull, throbbing, burning, aching, or stabbing. An example of what would be recorded is, describes pain as sharp and throbbing. Region or radiation identify the anatomical location of the pain and determine whether it extends or radiates to other areas. This would be recorded as, pain located in right lower abdomen, no radiation. Severity reflects the patient's reported level of pain intensity, as measured using a validated pain assessment scale. An example of what would be recorded is severity rated 7 out of 10. Timing evaluates the duration and pattern of the pain, including whether it is constant, intermittent, or occurs in a predictable sequence. This would be recorded as, pain is constant with intermittent worsening. A pain assessment should include an evaluation of the impact on functional status, including effects on mobility, sleep, and activities of daily living. This would be recorded as, pain interferes with ambulation and sleep. Objective findings provide supplementary clinical data, particularly in patients who are unable or have difficulty effectively communicating their pain. An example of what should be recorded is, Patient observed guarding abdomen and grimacing. All pain interventions must be documented, including the medication, dose, and route. An example of this would be administered ibuprofen, 400 milligrams by mouth per order. When documenting pain, there must be a reassessment following any intervention, utilizing the same validated pain scale to ensure consistency and accurate comparison of outcomes. This would look like pain improved to 3 out of 10. Anytime that a patient or caregiver is given education, it must be documented in the medical record, including the content reviewed and the patient's or caregiver's response or level of understanding. This would be recorded as educated patient on pain management options, verbalized understanding. Lastly, you should document a scenario walkthrough in the medical record for reference. An example of what should be recorded is pain rated 7 out of 10 using the Wong-Baker Faces Pain Rating Scale. Onset this morning with gradual progression. Pain exacerbated by movement and alleviated with caregiver comfort measures. Patient describes pain as hurting a lot. Pain localized to the left ear without radiation. Pain is intermittent and negatively impacts sleep. Charting tips. Always specify the validated pain scale utilized. Accurately reflect the patient's reported language and observed behaviors. Reassess pain using the same scale to ensure consistency. Document both subjective reports and objective findings. Lastly, use age-appropriate terminology. Thank you for watching this video on pain assessment. The Office of Correctional Medicine at Southern Illinois University School of Medicine invites you to look for more educational content in our Health Matters series.